yeah, we'll hear from quite a few different perspectives from North East London. We've got, as you can see, Lauren, Raquel, Lisa and Victoria joining us. So you'll really kind of hear the full spectrum from social sorry, link worker, commissioner, and GP around kind of what they're doing to show social prescribing impact. And yeah, I'll hand over to Lauren.
Thank you, Jenny. Fabulous. Yeah, this is our kind of overview slide. So hi everyone, I'm Lauren Moy. I'm the, well, formal title is now Senior Manager, Health Improvement and Inclusion brackets Personalisation. So work on all things personalisation in NHS North East London ICB. So I just want to give you a bit of a background to how we've got to where we are today. So the journey's been kind of approximately about 3 years now. The initial kind of exploration, as we knew that the CCGs and then finally the ICB and ICS were all coming together. It's a bit of mapping around what social prescribing teams were out there across North East London. So we had a variety of social prescribing teams across the 45 approximately PCNs in North East London. We brought everyone together as part of the social prescribing evaluation group, and that was just to get a sense of what the different social prescribers were doing in terms of data collection. Again, there's quite a lot of variety in that respect. Some people were just kind of making a few case notes, some people were using spreadsheets, some people were using kind of the clinical systems. And the idea was to kind of work together with the site that we knew that the national direction was going towards a minimum data set, kind of build on that and kind of decide, well, for North East London, what do we collect already and how do we kind of make a consistent approach to that data collection across North East London? So working with the social prescribing teams, we came up with this minimum data set a couple of years ago and launched that in clinical templates. So within EMIS and System 1, which are the two clinical systems mostly in North East London, built those templates with that minimum data set. And then we worked closely with colleagues in our BI team to create a dashboard in Power BI to represent that data visually. At the same time, we had a couple of our boroughs who were keen to go a step further on that and procure a case management system and directory of services. So Barking and Dagenham and Newham worked on a procurement for that system, which we've now got live. And so it's been really quite useful in terms of the quality improvement side of things, in terms of we obviously had the social prescribing minimum data set already, but then working with what was possible in Joy, which was chosen as our case management system, and also receiving the feedback after a year of use of the social prescribing template. We've now been building on some feedback on that, and our new template should be launched. You'll be receiving comms soon. I know there's quite a lot of North East London people here, but the comms soon will come out. We're launching the new template in January. And so we aim to implement after that kind of what the steps are in terms of improvement going forward for that. And I think I was going to talk for a little bit about why we think we've kind of managed to kind of get to this point of time with everything as well. So I think what's been useful for us is having obviously quite good quality improvement processes already in North East London, building in our data-driven social prescribing into the strategic aims as well across North East London. We've had extensive engagement across the social prescribing teams, our BI team, our clinical effectiveness group as well for building the templates. So I think it's kind of working across all those different partners. The procurement of the digital case management system, I mean, it took quite a lot of time. It was quite a couple of years end to end, but in terms of getting that procurement in place, it's been really helpful and we can learn lessons across the rest of the ICS. We've also got a good track record in North East London of voluntary sector investment. We're able to pool our evidence and insight and learning across North East London. I think it's quite important that we're building on existing assets. So we didn't want to do too much change all at once. We knew we had good stuff already. It was not kind of big bang in terms of bringing something new in. It was kind of building on what we already have. I think it's really helpful as well. We've had some really great committed time from our North East London clinical leads and digital and data experts as well. It's really beneficial for us.
Amazing. Thank you, Lauren. It's great to hear kind of how supportive the ICB has been, and I think what I'm taking away is that it's been the partnership between kind of the clinical side, the commissioner side and also working really closely with those social prescribing teams, so everyone can kind of come around something that's going to work for all people. I'm really interested to know kind of how it actually plays out in day-to-day practice for social prescribing link workers. So yeah, how does it kind of play out with your kind of all the other tasks you have to do? Don't know if Lisa or Raquel, if you want to come in on that.
Well, I find that my consult works better if I adopt quite a conversational approach, build rapport. I know the template well enough so that I can have my conversation, have the consult, go back, retrospectively fill it in, and then I feel as if the flow of my consult isn't interrupted necessarily by sort of somebody watching me, obviously, fill in a form. So I find retrospective completion better. I had some issues with the original template though, which were difficult, but I've worked with Lauren and I think there's going to be a new template released. Not just me, there were lots of people. So it was difficult sometimes to feel as if you were constrained by not being able to fill the data in its entirety. There were things that I wanted to have in the template which weren't there, and you always had to sort of adapt and find a way around it. And that was quite challenging, but then sort of we managed to speak to Lauren, find a way around it, and now I know that the new template is going to be released, and hopefully we'll have sort of more of a flow to the new template, and it will be easier to complete, and the data captured will be more relevant.
Thanks, Lisa. So kind of with that kind of retrospective completion, obviously that means you're taking some time out of your day. How do you manage to fit that in alongside your caseload and other things you're doing?
It can be challenging. So what I tend to do is I will make notes with the person as I'm having my consult with them. But I'm a touch typist, so I can still look at the person and have that conversation with them. I'm not necessarily clicking drop down boxes and checking, you know, which bit I'm dropping down. So I can still have a very conversational flow with somebody. Then when the consult ended, I try and make sure that I've got enough time so that I can fill that in at the end of the consult. So let's say I've got an hour, I'll take 40 minutes for the consult, have 20 minutes to go back and retrospectively fill in the template. If I've got those complex cases where they run over, then I have built into the end of my day an extra hour's admin time, which is my mop-up time for when I'm really struggling with some of those more complex cases.
Cool. Thank you, Lisa. I'm hearing that it's really important to kind of have that time built in throughout the day, and just, you know, it's not possible to really have back-to-back appointments because it's really important to have that time in between to make sure you can record the data. So thank you. Raquel, what's your experience been of kind of using the template?
Hi everyone, and thank you for inviting us today. It's been such a long journey, and I think I've been here with Lauren and everybody else from the beginning. The beginning was awful. Imagine somebody new going to a clinical system, trying to type in, being super scared of what am I doing? Am I doing this wrong? Am I coding things that I shouldn't? So it was really scary and time consuming. So when I learned about Lauren and what the team was working on, I thought I really want to get into this. And we've been working together since. They've been so supportive at many levels, not only with the template, but for me, the template has been a great aid, not only to my workload, time management, but also, how do I approach the conversation with someone? A lot of the things that we worked on to improve the template across time is being, should this section be here and not there, so that it flows nicely and smoothly through the conversation. So really, it saves time. It might take time at the beginning while you learn how to use it, but in the long run, it saves time. And then it becomes something as, after 3 years, I know what I'm talking about. I know all of the things that I need to ask. And, you know, just echoing Lisa, I will also fill in my template after my consultation because I want to have my full attention. Some calls last 1 hour. Some calls are follow-ups and might last 15, 20 minutes. So, you know, you really have to be very cautious with the time you use on this. But yeah, for example, an initial call and initial consultation under the template might take longer, but follow-ups are much, much faster. So yeah, it's been great to have something that is got all of the codes that you can quickly tick, and then that you can go back and track your consultation and see it. It's almost like a snapshot of, oh, right, I remember what happened with this case. So really, really very, very helpful at many levels.
Thank you. I've just seen someone put in the chat as well that could we share any of the templates and resources. So I'm wondering if you're able to kind of share on the screen just to kind of show yeah, what it looks like so people can kind of get more of an idea.
Definitely, I can try. Do I have consent to share my screen?
Yeah, I'll stop sharing mine. I guess in the meantime, just wondered if anyone wanted to share kind of how kind of the template and the data from that's being used kind of by the PCNs.
Yep, that's fine. I'll have a chat about that. So I know that as sort of link workers, we've talked about how our time is really precious to us because we want to spend it with our patients and support them. We don't really have time to be able to necessarily feedback some of the data that's requested by our line managers or the management. So what's the word I'm looking for? Dashboard. The dashboard can be accessed by the management and they can see all of that snapshot data. It's not beholden on us anymore to be able to provide that. So I find that really useful to be able to say to my line managers, you know, could you just have a look at the dashboard to be able to see that? And then I feel that it saves me another job, which is great because I'm retrospectively filling in my consults from the patient. So I find the dashboard really useful.
Amazing, thank you. Are you able to share your screen, or is it not working? Yeah, should we have a look?
Sure. I just wanted to leave Lisa on the spotlight. Didn't want to come up with a lot of information, but I'm ready for you. So I'm gonna share. You tell me. I got different screens, so please do. And I cannot see you now. Okay. So tell me if you can see it.
Yeah, we can see that.
Okay. Is it big enough for everyone to see?
I think people can click zoom if they want to zoom in. Someone's also asked if the template's on Joy, EMIS or System 1.
I think Lauren is going to be able to tell you that, and all of the intensive work that they are doing to sort of link all of those platforms with the template. But just to give you a very, very quick snapshot of what the template looks like. Earlier I took this dummy patient and I made a consultation so that we can go back now and see certain things, right? But if I go to my EMIS and ask for the template, of course, it will always come here. We are on version 1 already, as you can see. And as this opens, EMIS is it's not known by being quick. So you know, bear with us. It will come in time. That loads up. And the first thing that you will say is here we go. What is the type of apologies? Apologies, that's just I came out unexpectedly. We go back.
While Raquel gets that up, do you want to kind of share how it's being used across the different platforms, Lauren?
Mm-hmm. Yeah, absolutely. So yeah, we've got the original template in EMIS and System 1 currently. In terms of Joy, the teams are just using Joy as it came out of the box at the moment, but Joy are also building the template for us. So because we spent the last kind of year getting the feedback from the social prescribers, working across, looking at the national minimum data set codes, which I think you'll hear about a bit later, and also looking at what options were available in Joy, we kind of spent some time combining all that information to have a one list of minimum data set that will be rolled out in January. I need to loop back with Joy. Joy have been building that into their template, so I just need to check on the timelines with Joy as well for Barking and Dagenham and Newham. But yeah, the idea is that across whatever system you use in North East London, be it System 1, EMIS or Joy, eventually we should have the same template, same data set being collected that will then feed through to our Power BI dashboard.
Amazing, thank you.
So as you can see here, you can choose the type of consultation, whether that is a telephone consultation, a video conference, a face-to-face, or even an email, because a lot of patients do prefer to communicate via email. And that will take you in here on this side, that will take you to the assessment itself, the first assessment. And now you'll be able to see in the first and initial assessment, you will be able to use all the codes. So no need to know the million of codes that you could use on EMIS, but these have been picked up for you, cherry-picked. So you just have to click, right, this person was referred, and what was the source of the referral? Now we can pick, and this is going to change again, as you know, and Lauren has mentioned, the new version is coming up with even more codes. But you can choose what was the professional referring the person, whether this is being declined or not suitable for the person, and you can gather a lot of wider determinants of health here about employment, about housing, what was the main reason for referral as well. So there are a few options. All of these, I think, that have increased now based on feedback. We have some free typing to add our own case notes. And then the support offer. This is when it comes very, very interesting, because we can choose all of these. You know, have we talked about exercise, signposting to community, nutrition and education, substance abuse. You know, what other sort of support we given the person, signposting or referring to voluntary services, etc., etc. And here we have a tool that we use nationally, which is the ONS4, the Wellbeing Questionnaire, and we will just ask these questions to the patient and record them here, which, as you can see, I wanted to add this before because my previous scores are there. So on a follow-up, after I have completed my first assessment and we have a plan, I will be able to ask the person and see what is been the changes, you know, and ask the person what is made those change, what has changed for you to feel differently now. So that's it. There is a longer, wider determinants of health section now here that is very concise. It's been recently added, and of course we also record ethnicity and language needs. You know, I hope that gives you a brief a snapshot of what the template looks like.
Thank you. Thanks. That's amazing. Yeah, I was wondering. Yeah, is there a way that this can be kind of shared with different places that want to do similar things? Lauren, is there kind of a way that can be made possible?
Yeah, I think what we were hoping to do is kind of we can share the codes that we're using with people. I think normally we have to get permission from our clinical effectiveness group in terms of sharing actual templates and things like that. So the very bare minimum, I can share the codes and the groupings of them in the pages that we have.
Amazing, thank you. So I can see Victoria's joined us. So yeah, it'll be who is the GP in North East London, and is also the North East London lead for innovation. It'll be great to kind of hear kind of what the introduction of this template and the data set has meant for you, and kind of the impact it's going to have in primary care.
Thank you. Yes, well, I've been part of this journey from the very beginning, and our aim of creating the template was multiple, actually. Was first of all to ensure that we help the patient so that they don't have to repeat themselves many times in terms of their wider needs that they have. So we wanted to record this in a systematic way that are easily accessible to all the members of the team. We wanted obviously to help link workers to do their job better. So it had to be an easy tool to use that is quite easy to understand. We wanted to help the wider clinical team such as myself as a GP. Obviously, link workers have more time than I have to identify all these wider determinants of health that are so important for a patient's well-being. So when they take this very detailed history on the wider determinants of health, and I can see the findings of that conversation, it really helps me as a clinician to understand some of the patient background as well. And also it helps the system, as was mentioned before, to understand what is the population kind of healthcare need there, what are the resources that we have available locally, both by the VCSC sector, but also the local authority to respond to these population needs. What is the capacity of the system to respond, and whether we need to actually be investing more effort and resources within our local systems, both as commissioners, but also as integrated care leads within our PCNs and our integrated care teams. So it has been very useful, this template, from many perspectives. And now I'm going to talk as a researcher as well. Having access to this amazing data helps us actually try to answer some more interesting questions. So I have two researchers at the moment. One is looking at how social prescribing is used perhaps differently for people who do not speak English, so with language barriers. And the second researcher is looking at the effect of interventions, arts-related interventions, and when do we use arts-related interventions for which clinical problems, and are they effective? So they're really interesting questions that can give us very rich insights into what works and why. So it makes, I think the findings will help us develop better services, better care for our patients. Thank you.
Amazing. Thank you, Victoria. That's really, really helpful, and great to hear that kind of some of the data is being used to explore more in depth. There are a few kind of questions in the chat about kind of having access to this data and who's kind of taking it forward. I wonder, in the interest of time, if they can be kind of answered in the chat, or if they require a bit of a fuller response, then we can take them away and provide something after. And also, if you are interested, there'll be a breakout room hosted by Lauren at the end. So that'll be at about 1:30. So if you're still around then, or if you need to leave and come back, then feel free to do that. And then you can ask some more in-depth questions about this there. But yeah, thank you so much, Lauren, Victoria, Lisa and Raquel. That was really in-depth and really useful.